Okay, all right. Well, good morning, everyone, and welcome to the 2024 Mental Health Summit. Yay! Finally happened. Woo! Right? Okay, very good. It's such a full room. This is awesome. Okay, my name is Melina Taylor, and I'm the program director of the Community Psychology Department. And the reason why I'm up here today is because I'm the faculty sponsor for this event. So this is my first year doing it. So I'm really excited to be part of this. So this year, our focus is on community transformation through harm reduction, innovation, and care. Alverno College Community Psychology Program has a time-honored tradition of incorporating a passionate stance when supporting mental and physical wellness in the greater Milwaukee area. One major part of our mission for the summit is guided by our belief in providing easy-to-understand psychoeducation that makes information accessible to all. Our approach is grounded in both practice and research, and we're thrilled to collaborate with others in our city who share our dedication to substance abuse care. Today, we will embark on this journey of transformation towards positive change together. Ladies and gentlemen, esteemed professionals and eager students, those that are required to be here that are in my class, I know you're very eager. I stand before you today with a personal story of transformation, progress, and hope. Picture this, me as a much younger clinician whose first encounter with the concept of self-harm reduction left me in awe. It was like stumbling upon a glimpse of unconventional wisdom, radiating with the principles of humanism and unconditional positive regard. And it just made sense. During my time in graduate school, my research advisor, a psychologist with a private practice in New York City, whose expertise in substance use treatment has led to many published works on addiction, shared a profound story with me. She spoke of a 30-something-year-old female client who, despite societal expectations, managed her heroin use with remarkable control, indulging only twice a year. Initially astounded by this seemingly paradoxical behavior, I soon realized my own misconceptions. You see, I had been conditioned, as many of us have, to view substance use through a lens of shame, judgment, and fear. Clinicians and practitioners often approach those struggling with addiction with a heavy-handed dose of moralism, perpetuating a cycle of stigma that only serves to deepen the wounds of those already battling with themselves. In this story, what struck me most was not just the client's ability to control her substance use, but also my advisor's response. Instead of succumbing to the all-too-common impulse to want to control her client's journey to sobriety, she approached the situation with empathy, understanding, and a deep respect of the client's choice. She recognized that addiction is a complex and multifaceted issue, one that cannot easily be encapsulated by notions of right or wrong. She outlined the principles of non-judgmental support, prioritized the reduction of harm over abstinence, promoted human rights, dignity, autonomy, and respected her client's worldview. Her willingness to set aside preconceived notions and meet her client with this type of acceptance opened my eyes to a new way of thinking about compassionate care and how that could be experienced. It made me question the rigid dichotomy between healthy and unhealthy, good and bad, right and wrong, that pervades our clinical discourse. Upon returning to Wisconsin, I found myself in a landscape still tethered to outdated paradigms. The prevailing notion insisted on sobriety as a prerequisite for addressing underlying issues, shackling individuals in a cycle of unmet needs and missed opportunities for healing and wellness. Due to this atmosphere, I hesitated to immerse myself in the substance abuse treatment environment, grappling with the misalignment between my own values and the prevailing practices. In all honesty, when I was asked to serve as the faculty sponsor for the summit, I was less than excited, assuming that I would be in a position of convincing my colleagues to embrace that harm reduction does not encourage use, does not enable risky behavior, or oppose recovery, and finally, that harm reduction does not make communities less safe. But today I stand here brimming with joy and optimism, for Wisconsin has caught up with the tide of progress. Harm reduction is no longer a distant dream, but a tangible reality, having weaved its way into the fabric of our clinical landscape. It fills me with immense pleasure to witness the proliferation of harm reduction initiatives across our state, offering a beacon of hope to those in need. Today, we stand at the threshold of a new era, one characterized by compassion, pragmatism, and a steadfast commitment to meeting individuals where they are. So let us embrace this journey with open hearts and open minds. Let us champion the cause of harm reduction, not just as a clinical approach, but as a testament to our unwavering dedication to humanity itself. Together, let us forge ahead, igniting sparks of change that illuminate the path towards a brighter, more inclusive future. Alverno College proudly presents this dynamic annual event, bringing together our students and esteemed mental health practitioners to delve into pressing issues that shape our community. This vibrant gathering is a testament to the collaborative spirit of our community psychology, school psychology, social work, music therapy, and art therapy departments. With heartfelt gratitude to our sponsors, whose generous support fuels our ongoing commitment to this enriching experience, I would like to take this moment to name our 2024 sponsors. Rogers Behavioral Health, alumna Rosie Perpero-Spang. Apologize for all the papers stifling here. There's a laptop up here I'm sharing space with. Community Medical Service, Pathways to a Better Life, LLC, and Wraparound Milwaukee. And now for a brief, there's a shout out over there for Wraparound Milwaukee. And now for a brief overview of the day. I'm sure the time that you've all been waiting for to hear how your day will go. All presentations will be held in the Bucharest Conference Center. There's 3 sections, A, B, and C. And we are currently in Section B. Section A is closest to the lobby, and C is around to the other side. Consult your program for the room location of the breakout sessions, and your name tag lists the session number that you are registered for. For virtual participants, we are using the same Zoom link for the breakouts. Breakout sessions are 1 hour and begin at 10 a.m. and 11:15 a.m. All are welcome to stay for the networking hour from 12:30 to 1:30 p.m. And if you ordered a box lunch, they are available for pickup in the East hallway. We invite you to please visit the resource fair from 12:30 to 1:30. That will be in Alumni Hall, right across from the conference center. Participating organizations are listed in the program. And this is a last-minute thing, very exciting. There will be a special raffle at the resource fair, and the winner of the raffle will receive a substantial financial scholarship to be applied towards their treatment. Please look for that raffle at the resource fair. I won't tell you which resource has it. You guys have to find it. Restrooms are located behind the wall of the flags in the rotunda when you first walk in. For those that are interested in CE credit, that would be me. Each session is worth 1 CE hour. For those in person, be sure to sign in and out on the attendance sheet in each session. And for virtual participants, be sure your screen name matches your registration so we can verify attendance. You will be required to participate for at least 47 minutes of a 60-minute session to be eligible. All participants seeking CE credit must also complete an evaluation form for each session, and you can find them linked to the QR code on the program. In addition to CE requirement, we do value feedback from all participants. By completing the general evaluation form, you'll help us improve the summit, focus on topics you find relevant, and learn about ways to become more involved in the community psychology at Alverno College. We're also currently forming an Alverno advisory committee for the community psychology's accreditation. So please make sure to check the box for us to contact you if you'd like to be part of the board as a community stakeholder. I would like to thank the Summit Planning Committee for their hard work, time, and commitment. The summit would not have been possible without the efforts of the following names. But before I name them, I just want to say that, I inherited this role to sponsor this as the faculty, and I was really nervous about it because I was like, I have to do some whole new thing, and they were like, no, come on in, it's fine, we got you, and they did. They'd have me, so they really embraced me and taught me like what I needed to do. So the committee is really, some of them they don't work with Alverno, they don't work for Alverno, we don't pay them, they're community people, and without them this definitely would not be possible. So the following people I would like to thank: Julie Borgelt, Audrey Berghardt, Maria Castillo, Janet Gatlin, Maria Guardiola, Kelly Henkel, Leslie Henry, Desiree Israel, Megan McNeil, Tammy McLoof, Jeff Moulter, Lucy Stodecker, Natalie White, Jessica Weltenbrink, and Jean Zotner. Finally, thank you to all of our presenters, wherever you all are, for sharing your time and knowledge with us today. I'm now honored to introduce our keynote speakers, but first I'd like to highlight that while harm reduction primarily focuses on public health strategies to minimize the negative consequences of substance use and their risky behaviors, we are also recognizing how emergency services like fire rescue and paramedics play a crucial role in ensuring community well-being. In light of the evolving management of emergency calls, it is relevant to explore alternative approaches, like the one implemented by Greenfield Fire Rescue. Our first speaker, Dan Weber, is the Assistant Fire Chief of Community Risk Reduction and the Coordinator for all risk reduction efforts for the City of Greenfield Fire Department. This is an initiative that leverages community resources to not only address immediate emergencies, but also to proactively reduce 911 utilizations and mitigate risks throughout the community. This transition highlights the interconnectedness of public health initiatives and emergency response strategies in promoting overall community safety. Secondly, I'm also pleased to introduce Maggie Sutton, CSW, who works within the fire department, but also supports and works closely with the Greenfield Police Department and Greenfield Health Department. She's built the case management role from the ground up and now mentors other case managers and social workers in other Milwaukee suburbs. So if you can please join me in a round of applause to welcome our speakers. Thank you. And now you guys can have the whole podium to yourselves now.
Thank you.
All right, thank you. But it's not large enough because
I know, right?
there was no room. Thank you.
All right, good morning. It's Saturday morning, and I figured I'd dress down a little bit too, but it's nice to be able to dress in jeans. So
I always dress in jeans,
Yeah.
and I am a social worker, so I always have a cardigan, and it's just my getup. But this is what I look like on a daily basis, as social workers out there know.
for Zoom, should we stay in a specific area we can go? We're good? All right,
Okay.
cool. Well, we're gonna touch on some kind of heavy topics too today, but we are gonna keep it light, refreshing, and fun, because Maggie and I work together on a lot of different things, and we like to have fun, because you can only laugh so much in your lifetime, so we might as well laugh as much as you can.
Absolutely.
So today, our objectives. You're gonna be the clicker.
Oh, I'm the clicker.
That's right.
Yeah. We also have this dynamic because we work so closely together that it's like, this is just how we operate. We are not like the professional speakers. This is just us doing our thing. So please bear with us.
Yeah, thank you, Melina, for that wonderful intro. Appreciate that. All right, yeah, what do we have? Click away.
Oh,
Too many clicks.
I know.
All right, so yeah, today we are going to...
we're also working off of two computers.
Yeah,
so
we're gonna
I
try
was
it.
watching this one thinking it was clicking, and it wasn't. So
All right.
Sorry.
So today we're going to explore some emerging trends I think you'll find very fascinating across the country. We're going to focus on Milwaukee County, but we are doing some really cool things in the fire service to reduce 911 utilization. We're going to identify our local resources that we needed in Greenfield to make this happen. And then we are going to flip the script a little bit and talk about some of those harm reduction strategies where we leveraged public health and worked with them. Actually, they leveraged us. So,
And
but yeah.
police.
And police, yes. Next slide, please. All right. So a little history on 911. For those of you that don't know, 911 started back in the late 60s. Before 911, you had to call the operator, 0, and say, hey, can you connect me with the local fire department or police department? Or you had to call them directly. So it's police and fire together, they're like, we need to have a central number that everybody can call, something that's easy to remember. So this is great. 911 started in the late 60s. One call, that's all. Thank you, Mr. Gruber. And you can access 911. It goes to a dispatch center, and they can send you all these different resources, which is great. But we kind of shot ourselves in the foot. We didn't tell the community, like, what's a true emergency when you should use 911, and what is not a true emergency when you should use 911. So today, 911 has evolved in, my basement is flooding because my sump pump is broke. I need the fire department to come out and help me squeegee. There's a bat in my attic. Can you send a fire department to help me with this bat? We do get a lot of animal rescues. I have been in the fire service for 25 years, and I have yet to save a cat from a tree.
Oh.
But
Maybe this is your year.
this could be it. Yeah. But I have saved a lot of little ducklings and gooselings. Geeseling? Baby.
Gosling.
Thank you.
Thank you to the crowd.
Goslings, thank you. So yeah, when Mama walks over the sewer grates, all the little babies plop right through it. So, but we are called a lot for that, and we save that. So yes, 911 has been used for everything. In the police side as well, and just the emergence of the cell phone. You used to have to be at home, to call 911. Now you can be driving on the freeway and you can call 911. Somebody just cut me off. Or you can call 911 for my neighbor's dog is barking too loud and too long. Or police have responded to a neighbor where their motion light is too bright. So a lot of neighbor disputes. So 911 is used now for everything. It's the catch-all. So we needed to find a way, dispatch is like trying to prioritize all these calls. They're like, okay, chest pain, that's a heart attack. That's high priority. Neighbor's dog is barking. Let's stack that. Let's just keep them waiting, So there are medical calls though too, and that are not really true emergencies. So our dispatchers have to stack those and prioritize those. When we respond 911 as medical professionals, we have to respond, number one, it's in the legislature, it's in the written statutes, and then we also have to transport if that patient wants to go to the hospital. We can't say, no, we're not taking you. If you want to go to the hospital, we have to take you. So there's a dilemma. This has increased call volumes throughout the county, throughout the country. This has also increased your wait time in the emergency department. So we're taking everybody, no matter what kind of medical condition it is, we're taking them to the ED, and now you may have to sit in triage for hours. If you've ever been to some of our local hospitals, depends what it is. If you break your arm, break your finger, you may be sitting in triage for a little bit longer because there's people with chest pain, people having strokes, so they take priority. We, out of this, the fire service about 15 years ago developed this really cool initiative called Mobile Integrated Health. And what it is basically it's leveraging paramedics to become what's called a community paramedic. And I like the analogy, I was telling you about it.
Yep.
Maggie didn't hear about it.
I didn't.
Cheez-It commercials.
Yeah.
So there's a Cheez-It commercial where mom and dad are talking to the daughter, and mom looks at it and is like, how do they get the cheese in this cracker? Well, the daughter's like, I know. There's this big cheese wheel like rolling down the street. And then they stick a cracker out in the middle of the street, and she goes, Cheez-It. All right. So a community paramedic is exactly that. It is a paramedic rolling down the street, and you stick a social worker out in the street. Cheez-It.
Cheez-It.
Or community paramedic.
Yeah.
So a community paramedic is basically that. It is a paramedic that has had some extra training on a lot of those social service skills. You sprinkle in a little social worker, you sprinkle in a lot more empathy,
Compassion.
Yes, a lot of compassion, a lot of patience.
A lot of patience.
Yes. So emerging from that is fire departments now are using community paramedics, going out and finding patients that maybe call 911 a lot and trying to figure out why they're calling and connect them to the resources instead of the ED. That's the goal. The goal is to get them, number one, to the proper resource. Maybe it's just connecting them to a primary care physician. Maybe it's just, hey, you should maybe access the urgent care for this kind of thing, not the ED. But it's really meeting them where they're at and finding that correct resource, which is usually not the ED. Milwaukee Fire, you're going to hear from them today. They have a session. They're going to talk all about their overdose response initiative. Maury, amazing work they're doing. They also have community paramedics that are going out every day trying to find patients that access 911 repeatedly. West Allis Fire is doing some really, really cool stuff. They are, I do believe, they are the first fire department in the state that actually took somebody off shift, like technically on shift, working 24/7, 365. You have a community paramedic that's working all the time. So they give them a radio, they give them their own car. So during the day, they can go out and they can find patients that call 911 a lot or that may need some additional resources. And during the night, they can respond and help out their brothers and sisters on those 911 calls. Maybe it's a cardiac arrest. They can be there talking to the family, telling the family like what's going on. Okay, we have a tube in their throat, we're breathing for them, all that stuff. So a really cool, innovative approach on what they're doing in West Allis. And some of these programs actually have payers that are paying them to do what they're doing. Milwaukee may get some money from insurance companies, grant money. West Allis also has some contracts with payers, hospitals, the VA and West Allis Memorial. So some really, really cool. I mean, Madison Fire, Madison, Dane County, more progressive, I think. Well, I don't know, Milwaukee's right there.
We are. I think Greenfield's pretty progressive, but Madison definitely started ahead of the curve.
Yeah. So Madison Fire started, they have their community paramedics as well, trying to reduce those 911 calls, but they also started what's called the CARES team. And it is, if you haven't heard about it, community, do you remember?
No.
Community Alternative Response Emergency Service. Let's go with that. I think that's what it is.
Sounds right.
So the cool thing about this is this started in 2021, and it is basically a community paramedic and a crisis mental health worker. And they're out in a car with a radio and some supplies, and they're actually taking 911 calls. So they're not going, after the fact, follow up here and there. They're actually getting dispatched by a dispatch center when normally they would send a police officer. They had found in Madison that police officers, on average, spend about 60 minutes on a call, an average call. For mental health crisis calls, mental health 911 calls, they were spending over 3 hours. So in their first year with one team, and I think they added a second now, they responded on over almost 1,000 calls and were able to connect patients to resources, instead of a police officer having to respond. They followed some national standards where, you get better success when somebody shows up that does not have a firearm. So really, really cool, innovative stuff going on in Madison. We'll talk a little bit about our team. So Greenfield's actually right across the street over here, south side suburb, about 40,000 people. And our team started around the same time as Milwaukee and West Allis. Our budget did not allow us to hire additional people, so we kind of had to go to referendum for Maggie's position. Something about 2% levy and all this stuff. So we actually had to, ask the taxpayers, is it okay if we hire 2 firefighter positions? And we wanted to make sure that Maggie's position was in the fire department, in our budget. A lot of case managers are showing up under health.
Yep, public health.
Public health, which is great too. But we wanted Maggie for our own. First.
And it makes sense, and we'll get into that.
First and foremost, we wanted, yes. So myself, Maggie, and then we also have 6 community paramedics. What's unique with us is they're also on shift responding to 911 calls, and then when they can, they'll put their med unit down, and they'll go out and they'll do those house calls, find those high utilizers, frequent flyers, But something had to be done. I was talking about strange 911 calls. We've been called for chapped lips. We have to take them to the ED. Mm-hmm. We've been called for a hangnail. Had to take them to the ED. But we do get a lot of calls for the unhoused, the homeless, and they may just want a sandwich, something to eat. And we do take them to the ED, and they do get their sandwich from the ED, which is great.
Yeah.
But talk a little bit about your position.
Sure. Yeah. So I am the first social worker in a fire department in the state of Wisconsin, and when I accepted this position, I asked, what exactly are the expectations of this role? And I was told, I don't know. Figure it out. And so my background is Child Protective Services, and there's no figuring it out there. I mean, you do assessments and investigations, but there's standards, there's rules, there's very clear expectations of that role. And so I was allowed to create this position and figure out exactly what the city of Greenfield needed. And I'd worked in Milwaukee County and I knew Greenfield, but I had no idea what the fire service looked like. I had no idea how many times a day the ambulances were going out for these non-emergent calls and how often people utilize 911 over and over and over again. And so my first year of employment, I really just looked at the calls. I tried to connect with resources in the community because as a social worker, we know that our toolbox is everything. And so I just started partnering, and trying to figure out exactly what these calls were, why were these high utilizers calling, what could we do with our overdoses, how could we reduce those overdoses, how could we just, like Dan said, and the trend of harm reduction, meet these individuals where they're at. Meet them where they're at. And that means a lot of different things. For me, that means meeting them in their home, right? Like physically where they're at, in their car, under a bridge, at a restaurant, whatever, but also where they're at mental health-wise, physical health-wise, just meeting them with compassion and empathy. So for me and those resources, it's really everything. And I had full backing from my fire chief, our former fire chief, Dan, and it has just grown so amazingly in the last 4.5 years. And I'm very, very proud of that. So, resources, my toolbox. My toolbox consists of the Aging and Disability Resource Center. So we work in our aging, we work in substance use, which we'll get into a little bit more. Our local health department, 211, hospital, ED social workers, and general medical social workers that have our high utilizers that are going to be discharging those patients, connecting. Placement agencies such as A Place for Mom. So if you're not familiar with a placement agency, it's an agency that assists families in getting their aging relative, family member, whoever, into an assisted living when they're ready. Again, it's meeting that person where they're at. If they're not ready to leave home, that's okay too.
If they've called 20 times for lift assist, are they ready?
They might be ready, and we're going to have that discussion.
Okay, that's
yeah. A lot of hard discussions being had, and understanding why they want to stay at home. But it takes a lot of time and a lot of effort to do those tours and to make those connections with those assisted livings. And when you have a tool to be able to do that for you, it makes my job so much easier. We found in Greenfield that we have ebbs and flows of our unhoused population, but I'm in the community. I see the people that are, panhandling and don't have homes. And I did not come from this area of work, and I had no idea what to do. And so through different agencies like CMS, who had already been connected with Street Angels, I connected with them, and they became one of our largest partners, our biggest supporters. And then they actually connected me with Coordinated Entry. So Coordinated Entry in Milwaukee County is where individuals call 211, connect with a call taker, and then get on a list for housing. But those individuals have to call over and over and over and over again, and they could be unhoused for years. If their criteria doesn't meet what the county says, or they aren't homeless long enough, they will not get housing. So I took it upon myself to go to the top of Coordinated Entry and connected with Eric is his name, and I now have access to directly to Coordinated Entry. I provide the information, so those individuals that are vulnerable and may not have the capacity to call 211 over and over and over again, I do it for them. We have, like every community, many residents that have mental health challenges, and when those people are ready or willing to receive care, we connect with Rogers, Aurora Psych, Granite Hill, and of course substance use, which we have a tremendous program in the city of Greenfield, our substance use disorder program, which we will go into in detail in a little bit. We work very closely with Community Medical Service. We partner and have agreements with Maury, who's going to be speaking later, and West Dallas in their SUDS program, so we can communicate and discuss patients that we may both have and make sure that those patients are being seen at the quickest time. And Clean Slate. I always forget about Clean Slate. They're in our community, and we work really, really close with them. But I think of CMS often because we have a peer support specialist, so someone in recovery working with our agency, and so we've worked extremely close. But we do have Clean Slate, and they're in Greenfield as well. And then home care agencies, so therapy at home for those individuals that are falling often or weak, Comfort Keepers, Synergy, so just caregiving, companionship services, whatever those patients need.
And those are usually our first line as a community paramedic when we go and respond for somebody that's been falling a lot. It's calling 911 for lift assists. Those are our first calls. We'll call a home care agency. Hey, we'll ask the patient, do you have a little money that you can pay, for a home care agency weekly? If they do, or if they're a veteran, that's even better because the VA pays, for this, which is great. So yeah, we call them and, hey, can you help this person out so that they don't fall as much?
So in the beginning, again, I had no idea what I was doing in this position, but like the leaders within the fire department, our elected officials in the city were also on board with this position. They live in our city and they want the residents of Greenfield to be taken care of and have that continuum of care from our paramedics, being discharged from the hospital. They want that follow-up for our residents, and so they were completely on board. One thing that I found, though, is that there are silos. There are silos within cities, the fire department, health department, fire department. There were silos. And so I spent an afternoon a week at the beginning in our police department. They saw my face. They got to follow up on calls and referrals that they had sent to me. And then I started getting called out to scene. And they would say to the person that had called, we're not equipped for this, but there's a social worker on staff. We're going to call her. And it's amazing because at first they were like, no. We don't want any assistance in our police department. And now it's like, we don't want to touch that, but we know someone that will and has more skill set. And so that silo in and of itself, the walls have been broken down completely, and that is a huge success for our city. Huge success. The silo to public health was much, much smaller. They knew that this role had a tremendous capacity in our city, and the trend with public health at this point is they're not out in the community. They're getting the calls. They're hearing the stories, but they're not able to fully.
They used to be.
They used to be.
Back in the day, that
Yeah.
public health nurses would respond, go to homes. Now it's, more TB cases and things like that.
Yep. And so they weren't out in the community. They didn't know how to follow up with these patients. So again, it was, well, Maggie's out in the community. She's seeing these patients. She has no fear of knocking on a door or making that phone call or connecting with these resources that she has already established. So this beautiful, beautiful partnership between all three departments happened, and really amazing things started happening in our city. We have a tremendous overdose fatality review, and everyone's at the table. We partner at events, community events.
Yeah. Fall prevention.
Falls prevention. There's just a ton of partnership within our city.
Yeah, and then it's truly about reducing stigma, a lot of stigma in police and fire departments on a lot of harm reduction topics.
Yeah.
And even the unhoused, the homeless, like I myself had to have a change of heart. I needed a little sprinkling of that empathy and some compassion for myself. I was the kind of guy that would say, why don't you just get a job? Stop sleeping here at the park and ride. Get a job and, hey, get an apartment. They're $400 a month. Well, I think they're more than that now.
They are much more than that now. I don't know what year you're living in.
Yeah. Well, maybe like a studio or something? I don't know. Okay, so I'm still learning. Like,
thank you, everyone, for bringing it back to reality.
Yeah. So it had to change in my heart, and we had to have some changing in the fire service and police as well. So, it starts internally.
Absolutely, and that change is typically very slow, but we're seeing it. We're seeing when our paramedics ask me about my follow-up contacts with our patients, you can hear their concern, their true, sincerity in this patient's well-being, and it's slow. At the beginning, there was a lot of judgment towards our patients, and that's decreasing as time goes on.
That's good. Talk a little about harm reduction as well in Greenfield, and some of the biggest thing right now. Well, I feel it's the biggest.
You might hear a soapbox here for a second.
No, so falls.
Yes.
It's an epidemic.
Huge.
We're also part of the Milwaukee County Falls Prevention Coalition. Please join. We need to just expand and expand. Falls is the number one 911 call across the world. And it is no stranger in Greenfield. So last year we went on to like 8,000 calls. 1,600 of them were for falls or lift assists. 20% of what we're doing is falls and lifts. The next highest was like 7%, and that was for difficulty breathing. So falls and lift assists. And a lot of the patients that we see are repeat offenders, repeat customers.
Royalty customers.
Royalty, yes, royalty. And they may just need help up off the toilet, a lot of things. So connecting them to the proper resources through case management, through a community paramedic, getting them that in-home care, So it's kind of our harm reduction there with falls.
So with our falls as well, there's evidence-based curriculum called Stepping On. And so this year, my focus for falls is to do this workshop, which is 7 weeks, in our aging communities, because it is such an epidemic that, well, one, in the state of Wisconsin, or the state of Wisconsin, is the number one falls state in the U.S. We have more falls than any other state. We can't figure out why.
Alcohol.
We keep saying that, but that's not what there's. No. I don't know. That's not what the data says.
Yeah, true.
So we can't figure it out. I don't know. Maybe that's just a hidden data piece that they don't want to share.
Right. Well, yeah, alcohol or, the weather too.
Or the weather,
Yep.
Yeah. But people over the age of 65 die from falls. And we're not talking about that. We talk about our substance use patients or suicide, but people actually die from falls. And it's
mind-blowing.
Yeah, it's mind-blowing. It is. So that's my goal this year, is to do these workshops in our aging communities. So it's a big task, but I'm here for it. We've talked a lot about our unhoused population already. We do weekly outreach to our unhoused population. Just this year, we hired on a part-time position specifically for homeless outreach, and she is fantastic. She is connected with coordinated entry as an employee of Greenfield Fire, and she has the capacity to sit down with these individuals, do a full assessment, get an understanding of what their needs are, and if they want shelter, if they want housing, if they just want to continue living in their car, which people do. And again, we meet them where they're at, and we just try to connect them with whatever resources they need, make sure that their basic needs are met, make sure that they have food, make sure that they have shelter, make sure that they have water. We try to connect them with some place to bathe, to do laundry, and our part-time person is really good about just sitting down, filling out applications, making those calls, driving them to where they need to go. That program has grown.
Yeah, we used to have a cafe or
a deli.
Deli, thank you. A deli that would give us their leftover food, and then we would drop that off. We'd pick it up the same day, and then we'd go around, find our unhoused, and drop that off, give them as much food as possible. All the leftovers I would take down to...
Yep. Cathedral.
School. Yep, sure.
The
Yep.
Cathedral Center.
The Cathedral Center, yes.
Yeah.
And they were happy. Sometimes it's hard to get, a lot of places won't take food that's not like,
Yeah.
but
our deli
the
went out of
percentage rate.
business. Our deli went out of business. So if anyone has any suggestions on where or who might want to provide free food, we're more than willing to take it.
Yeah.
So, because we do have unhoused individuals in our city, like everywhere else. Okay.
Suds.
So the meat and potatoes of a lot of things that we do in Greenfield, our substance use disorder programming. So our programming actually started out of the police department initially. In 2016, the CARE program, Cops Assisting Addiction Recovery, was started by Sergeant DeGlopper. And he had done some training through an organization called PARI, Police Assisting Addiction Recovery Initiative, which is an organization out of the East Coast. And basically what he found is that our residents that had drugs or paraphernalia at the time of an overdose would not benefit from criminal charges. So he worked very closely with our DA's office and county DA's office with our officers, and he created an agreement that states if this individual that has drugs or paraphernalia at the time of an overdose goes into treatment for a minimum of 3 months, those charges are dropped completely. They're not on their record at all. And it has been a very successful program. So when I came on in 2019, I started going out on our post-overdose outreach with Sergeant DeGlopper, and I took over that program. And we have had really, really great success. And it is, again, it's meeting those individuals where they're at and building a trusting relationship. Because people think, this isn't true, this can't be true. If I go into treatment and I'm there for 3 months, then I'm not going to have charges? Absolutely. And along the way, I'm going to connect with you. I'm going to stay connected. We're going to build this trusting relationship. And if there's a moment that you feel like relapsing or using, I'm just a phone call, a text away. Let's talk about it.
Legit, one of our patients that we were working with overdosed and saved, but had Maggie's card and had his heroin wrapped up in Maggie's card.
Yeah.
It was very, very interesting, but clean?
I have not had contact with him in
Okay.
a couple of years, but there have been some really challenging times. I had an appointment with someone she had used right before that appointment. I couldn't get into her apartment, and I knew her so well. I'm like, she's overdosing right now. I called police. I called Amy because I didn't know what to do, she's from Maury and Clean Slate, and I didn't know what to do, and we got in her apartment and we saved her life. And she and I have had many conversations about that moment since then, and I'll actually talk about her a little bit more because she's clean today. Sorry.
Yeah.
Just getting a little emotional. So we have the CARE program, and then our health department, through the opioid settlement money, became a Narcan direct site, but they don't have the capacity to be out in the community. So I was already out in the community. I was already making contacts with our non-fatal overdoses. So we started taking it along and just slinging Narcan, literally slinging Narcan. And then
Narcan dealing?
Yeah. If someone wasn't home, I would just leave it there, and with my contact information and just to get it in individuals' hands. Then our health department was offered a grant opportunity for vending machines. And initially they were Narcan vending machines. And Greenfield is the second city in the state to have, we now call it a harm reduction vending machine, not specific to Narcan, because we have a ton of other stuff in.
Snickers? Are Snickers in there yet?
There's no Snickers in there, but there are safe sex kits,
Yeah.
gun locks, fentanyl test strips, Narcan, information guides, and they are highly utilized. So our first harm reduction vending machine was placed at our law enforcement center. It's 24 hours a day, and we in the city of Greenfield have a probation and parole agent right in our fire department or in our police department, and so she was making sure everyone was getting Narcan and harm reduction materials. And but people would just come in. I was in the clerk's office one day, and there was a middle-aged female with 2 kids getting Narcan, getting harm reduction materials, and I was like, this is amazing. So we have really, really broken the stigma of just utilizing these harm reduction materials.
We did get a lot of emails and questions from the PD and from officers, like, why is this in here? What the heck? This is going to bring the riffraff in here, but it didn't. You know, it's not. It was perfect.
It was perfect, but our agreement was, it was a pilot program at the PD, and part of that agreement was they would take a portion of their drug seizure money to buy us this beautiful machine.
Yes.
It is outside at Station 92, 92nd and Cold Spring at our office, and it is temp regulated. It collects its own data, but the other machine at PD had to be moved, even though it was tremendously successful.
Yeah, and right in the center of the city.
And right in the center of the city. But we moved that other harm reduction vending machine to Hyatt Pharmacy. So now we have one on 27th and Layton and 92nd and Cold Spring. So one on either side of our city. And they are used. Mm-hmm. They are utilized. We see people coming during the day to grab materials. Someone had an issue getting harm reduction materials out the other day, and Dan just happened to be at the office and went outside to help them. So our paramedics know. They were very concerned about people being in our parking lot and things like that, but they have stopped the questions. Yeah?
I'm just curious about the gun locks. Are those, I mean, I've seen them.
Yep. Yep.
But gun locks, are people utilizing the machines for that as well?
They are. They are. So in the city of Greenfield, we have had an uptick of completed suicides. And we are working diligently to try to stop that, because most of them are by gun. So we're actually kind of doing a public service announcement regarding gun locks.
Are there many of those machines in the world?
Yes, there are, and I believe someone's going to be talking about it today. Yeah? Yeah.
How many machines in the county? Yep.
Yeah. There's many. Oh, yeah.
They can't hear without a microphone.
Oh, sorry.
Gotcha.
Sorry.
We're gonna.
What do we do?
Yeah, we'll do 5 more minutes, and then we'll take some time for questions, and we'll pass the mic around. Sound great?
Yeah.
We also have the Narcan EMS leave behind, which is now, I think a lot of fire departments are using this. It's actually the opioid settlement money that went to the state, and then DHS was like, how many fire departments need Narcan? And we're like, we do. So Narcan and fentanyl test strips, they provide all the funding, and it works great. You just submit your invoices, and they pay you back. So now you have Narcan. In addition to the paramedics Narcan, this is the intranasal Narcan that can be used for anyone. So we leave that after an overdose. We'll leave it, and then Maggie will leave more, or community paramedics will leave more too. So it's a great program.
So in those leave behind bags, we have Narcan, fentanyl test strips, water, so individuals can actually use the fentanyl test strips, and then resources. My information is in there. We have these beautiful door hangers that we leave if someone isn't there. It's really a robust program. Do you want to talk about the new and upcoming information?
Yeah, so with that opioid settlement money, there's all these grants being submitted, or grant applications being submitted to the county for different innovations or approaches to how we can help. So OEM, Office of Emergency Management, will be submitting a grant application for some of that settlement money to utilize community paramedics in fire departments pre and post, to meet patients pre and post incarceration. And we're really kind of excited. I know there's the behind the walls, but this would be, we would reach out to them before or right after, within like 24 hours, try to see, if they need some resources, need a ride to CMS, need a ride to Clean Slate, wherever they need to go, and we'll make that happen.
Right, because one of the trends that we're seeing is that when an individual is released, they use very soon after that, and there are really no programs to help as soon as they exit those doors and the interim. And so this, again, bridges the gap in service, which is our basis.
Yeah,
always bridge the gap.
Very vulnerable population. So we just wanted to end quick with some success stories, and then we'll have some time for questions. But a fall success story.
A fall success story because of the epidemic, the unknown epidemic. So 78 female was falling. We actually didn't get called by her. She was just falling, and she was able to get herself up. So last fall, I did the Stepping On program at a senior living community. She signed up for it, and she had informed me that she had had many falls. And I was like, well, this workshop is perfect for you. And she came, she participated. We do strength and balance exercises. And I'm in this community quite often, and I run into people that I've worked with and whatnot. And she was in the community room one day, and so I popped in, and I'm like, hey, how you doing? And she's like, I just want you to know, this was probably January that I saw her, and this workshop was in September, early October. And she's like, I just want to let you know I haven't had a fall since, and I do my balance and strength exercises, and I want to thank you. That has helped my life. And so she probably would have continued falling. We probably would have seen her eventually through 911, but
yeah.
She
Nice
is
work.
no longer falling. So that's really exciting. 64-year-old male, unhoused. He came from Beloit, was living in a van.
Down by the river?
Nope.
Oh,
At a church.
okay.
He was still worshiping. And
That's good.
yeah. He had a plan. He thought he had a plan when he came from Beloit. He did not really have a plan and found himself residing in his vehicle. So we worked very, very hard to connect with Coordinated Entry, to connect with the Aging and Disability Resource Center because he had some disabilities, physical disabilities, and because everything takes a little bit of time, especially in government, within 4 months, he was in housing. And he really took it upon himself, which is so very necessary at times, but he took it upon himself, and he got housing. And then Miss 24-year-old female, substance use disorder.
You saved her life.
I did, yeah. But it wasn't until she had to Narcan someone that she understood the severity and the trauma behind what other people had done for her, because she had been Narcaned about 10 times.
Yeah, so her primary drug of choice was heroin and
Yep.
marijuana. She started her substance use journey with heroin at the age of 19.
Yep.
Immediately became dependent and started using intravenously. She overdosed 3 times in Greenfield, where paramedics administered Narcan, twice in A friend also administered Narcan once prior to paramedic arrival. She tried several types of treatment, partial hospitalization, medication-assisted treatment, individual counseling, case management, and intensive outpatient treatment. Her first post-overdose outreach with our team with Maggie was in 2019.
Yeah.
And she relapsed several times during Maggie and the team's work together. But she became sober in late 22.
And she is still sober today. I actually just talked to her the other day. And she owns a duplex. She has a job. Like, she's just rocking out. So I love that. And she's like just the coolest.
Yes. She gave a little quote here.
Yeah.
She said, "The outreach team made me feel seen and not like a bad person. They put humanity in addiction, showed no judgment for the choices I had made before and during knowing them. When I left treatment and relapsed, they were there with continued support."
Yeah.
So that's good. Good story.
It is a good story. So on our vending machines, there's a QR code, and we ask people to let us know why they're carrying Narcan. So life is precious. I want to save lives and give people second chances. You never know where or when you might need to use it, which is very accurate. And then every life is important. Every life can change. We do recover. Profound from the people accessing our services.
Yeah. Thank you so much for your time. We have like 5-10 minutes for questions. We'll move the mic around.
Just about one of the vending machines. You said it was on 27th and Layton. From my understanding, it's on the inside of the CVS. Yep, go ahead.
It is on the inside of the Hyatt Pharmacy, and it's accessible between 9 a.m. and 5 p.m.
So what about if it closes and they can't that's the closest to them and they can't make it all the way to the other side of the city for the other one?
There are other vending machines, so that's right next to Milwaukee, and I don't know where the next closest is, but there is a map.
Captain knows.
So you can, anywhere, any city of Milwaukee fire station, the closest one there would be, now it's reopened, would be 13th and College. Okay. That would be the closest one, but any city of Milwaukee fire station, all you have to do, go there, ask for a Narcan kit. Most people aren't going to remember ours, which are called Hope kits, and you can, so everyone can hear me back there. So that way you can access Narcan through any Milwaukee fire department station that's open. So if someone's there, as long as it isn't their last kit in the house, they have to keep one that for our leave behind program. But if they have additional, and normally we make sure we keep them well stocked, you can find one there. They give it out, no questions asked. You don't have to provide any information, just ask them for a kit. And
that would be the same with Greenfield fire departments as well. So we have 2 stations in Greenfield, 51st and Layton, and then 92nd and Cold Spring. So that's like right down the road too. But Narcan is pretty much anywhere.
Yep.
Yeah.
All right, and we had a question right here.
Sure.
All right.
And actually there is one out to reopen on 13th. That's 17th, recently reopened.
Oh.
Yes, thank you.
So that would be right down the street, 13th and Layton.
Dan, this question is for you. You indicated at the beginning of your presentation that when you call 911, the fire department comes out. How do you, when a person calls 911 and they say that whatever it is that their issue is, they determine whether or not that the med unit is coming or if a private is coming.
Correct.
So if a person calls and it's a private call of someone for private, and when I say private, I'm thinking of Curtis or Bell or Paratech. I think Paratech's gone, but one of those that will come out to whatever the issue is. On their units, is it still, in Milwaukee, I'm thinking Milwaukee now,
Yep.
is it still that there's a paramedic that's also on they're in their unit or private?
This may be a question for Dave, but yeah.
Thank you, Dave.
We have over 200 paramedics now in the city of Milwaukee. So not just on our med units, there's 2 meds on a med unit, obviously. We also have paramedic first responders, which are on our engines and trucks. So depending on how it's dispatched, if it's dispatched with a private entities such as Bell or Curtis, they cannot work, as weird as it sounds, they cannot work as a paramedic on that rig. That's just not the way the county works. It's only, they can when they're transferring between hospitals, but not on an EMS run, not on a 911 run. It has to be the city, for us, the city of Milwaukee. So we have paramedics sprinkled throughout the department that can respond, besides our team as well too, which are all paramedics and community paramedics. So I hope that answers your question.
Yes,
Okay.
yes, but the reason why I'm asking is because just recently, when we were talking about fall, we recently in the city of Milwaukee had a fall. And outside on one of the coldest days, and someone
yes.
died.
Yes. Yes.
And when she called, and I thought from years ago that if you had a cell phone, it pinged to where, even if you didn't tell them where you were, it gave you that area or whatever. This person made a 911 call, spoke to dispatch. Dispatch sent out a private. I'm wondering, how do you differentiate, whether or not this person needed a med unit, the fire department, or a private?
So the way our dispatch works is they just really have an algorithm, very similar to us as paramedics, an algorithm that they work from. So what they're being told by that person is like a school Rolodex, but it's almost the same thing. They're entering information, and our dispatch program then says it picks who should go. If it's going to be a private ambulance or if it's going to be 911. Now, I don't know the circumstances of that exact event, so whether they called them directly or it was initially 911 or vice versa, or I should say where they called that entity, they couldn't find them, then 911 was called, because I know that our units did show up and unfortunately we know that she passed. But that's kind of how dispatch for the city of Milwaukee works, is they just run through an algorithm. What you're saying, how you're answering questions is who is going to be dispatched. So I hope that kind of clears up a little bit.
Yeah, we can talk a little bit more after if you'd like, in between break.
Yeah.
And we have a comment over here,
Comment?
right here, in the corner.
Oh, hey.
Oh, sorry.
Hey everybody, I'm Jeremy Triple. I work for Milwaukee County. We were talking about vending machines earlier. I just wanted to indicate that we had a website called harmreductionmke.org, harmreductionmke.org, where you can go and find where at least 11 vending machines are. This year we're working with other municipalities who have vending machines. So if they want to put their vending machine location on that map that shows you how far away you are from a vending machine, we can do that as well. And then lastly, we currently have an application out for new businesses and organizations to apply to get a vending machine. So we'll be releasing 8 more vending machines this year and about 5 or 6 more next year. If you're looking to complete the application, become a part of the conversation, get in the running for a new vending machine, please go to harmreductionmke.org to apply for that. And if you're not, that's perfectly fine. Always go there if you're looking for a machine across the county. Once again, we're inviting other municipalities to also use that map and or add their machine location to that map as well.
Yep.
Thank you.
Fantastic. Thank you.
We have a question right
Yeah.
Assistant Chief, you had mentioned before that originally you, the way I'm going to phrase it is, became desensitized because of the fact that you have worked with so many emergencies, with so many calls, with so many things, but then have changed the way that you have looked at that. How did that happen for you? And was Maggie a huge part of that, which I'm sure she was because of how she speaks about everything, but how do we work with, let's say, Milwaukee and other areas that we work with? I work with adolescent youth. To be able to make sure that those that are constantly in an emergency mode, like you guys are, also understand that the empathy and the compassion is also still there, even 10, 15, 20 years of, I just came back from somebody who literally had chapped lips. Like,
Yeah. Great question. It was a lot Maggie, and when we started our team, initially I was responding as a community paramedic as well with Maggie, and we were going and seeing these patients, and then, you know, it's not 911, so it's not emergency, so you get a little more time to kind of get to know the patients and get to know their backstory and the life that they've lived, and it was eye-opening for me. And
So I think regarding just other members of our fire department, I try to eat lunch at the kitchen table with them, and that's huge, right? And so I hear them, and I try as a social worker to reframe and to have discussions with them about why they're feeling the way they're feeling about this patient. There are days, I mean, to be honest, that I am tired. I am tired of our high utilizers, and I have to kind of take a step back, or Dan will be like, I think maybe I'll go out to see them, you know? And so we really try to team with our members, and try to support them where they're at too, you know? But it's those conversations and just really trying to pass on that empathy and compassion. And I would say our members, though, are so compassionate. Like, the concern that they have, which is why they're referring them to me, you know, because they want to know that this patient is taken care of. And they know that in that emergency situation, they're not able to meet all of the needs of this patient, but then I can go in and, you know, pull away the layers and help them.
they have that option now to refer. And that used to be, if you didn't have a team like this, it was, let's just take them to the hospital. I mean, it's the easy button. Let's just take them to the hospital, take them to the hospital. So.
Yeah. So I think our time is up. Thank you all for being here and listening to us, and we'll be hanging around for a bit, so if you have questions or anything like that, certainly let us know. And then here's our contact information.
Thanks again so much for coming here and volunteering your time on a Saturday morning to educate us and collaborate with us. Okay, so what we're going to be doing now is everyone's going to be going to the breakout session that they've registered for, and that is on your name tag. For those of you who paid for a lunch, you have a green dot on your name tag. There's a few of them out there, so I don't want to see anyone taking a name tag. It doesn't belong to them. And then also, please remember that you need to sign in to get the credit for the CUs. Okay? If you have any questions, I'm here. There's other Alverno people. Just look for an Alverno name tag, and someone can usually help you. So, all right. Thanks, everyone.